Myself, Dr. Sunil Alexander, Secretary of SmartCiy branch. I cordially invite you all to the 12th CD program of this year. Today we are having with us Dr. Shihad Salim, who will be talking to us about hemostasis. I will request Dr. Deepak to introduce the speaker.
Thank you, sir. A very good evening to all. Myself, Dr. Deepak Thomas, CD Convener, IDA SmartCiy. Welcome you all for the 12th CD program of IDA SmartCiy in the month of August. In fact, we are blessed today to get one of the busy oral surgeons and orator from Trivandrum district. And let me say that he is one of my dearest friends since the last 18 years. And to introduce him, when we are studying itself, he was the MG University Union Councillor and College Students Union Chairman for 3 consecutive years. And when we are looking into his achievements, he won the best post-graduation PG paper award in the conference held at Trivandrum in 2012. And he was the invited speaker in the 5th Global Summit and Expo on Gender and Oral Diseases in January 2019. And he was a part of the 73rd Indian Dental Conference held at Kovalam, and he was also chairing a scientific session there. He was a speaker on 2021 World Hepatitis Day, and also he has written preface for 3 books of philosophical genre. I welcome you, Dr. Shihad. We are expecting a great session from you. On behalf of IDA SmartCiy, I welcome you once again.
Yeah, thank you so much, Dr. Deepak, for the intro. Shall we directly go into the session? Sir, shall we start, sir? Shyam, sir?
I request Dr. Shyam also to speak a few words.
Shihad and Deepak, they're my students in the undergraduate days. From those times, the both of them have flourished to a bigger screen and bigger extent. And I'm so happy for Shihad for his achievements, and I'm very proud in witnessing his presentation as IDA SmartCiy president. So we expect to have a great presentation, Shihad. Looking forward to it. All the best. Thank you.
Yeah, thank you so much, sir. Thank you.
Thank you, sir.
Deepak?
Thank you, Shyam, for the kind words. Dr. Shihad, the floor is yours.
Thank you, sir. Thank you so much. So, to start with, today, I'm going to deal on kaleidoscopic consensus on hemostasis, antiplatelets, and coagulation cascade. It is rather an overview on hemostasis, platelet plug formation, coagulation cascade, the activity of anticoagulant drugs, antiplatelets, fibrinolytic agents, and the antifibrinolytic agents. Me, myself, Dr. Shihad Salim, Associate Professor, Department of OMFS, PMS College of Dental Science and Research, Trivandrum. And this is my college. I'm having a screen share. So I'm going to deal on hemostasis today. And coming to the first slide, hemostasis is nothing but the stoppage of unwanted flow of blood. And while talking on hemostasis, we literally has to say about blood. Blood has got 4 major components. They are the platelets, plasma, WBCs, and RBCs. RBCs are represented in millions, WBC in thousands, platelets in lakhs, and hemoglobin content for males are considered to be on a higher range when compared to that of females. Apart from these basic elements, we also have 13 clotting factors that make up the blood products. And coming to the clotting factors, factor 6 does not exist. This is sheerly because the activated form of factor 5 is similar to factor 6. So the authors, in a period of time, have excluded 6 from the list. Factor 8, 9, and 11 being anti-hemophilic A, B, and C factors. Factor 10 and 12 are the literally nouns. They are Stewart-Prower and the Heisman factor. Factor 1 is a fibrinogen that can be converted to fibrin clots, stable fibrin clots. And factor 1 is being stabilized by factor 13, that is the fibrin stabilizing factor. So these are the 13 clotting factors. Being dental surgeons, in our day-to-day practice, we come across n number of patients who are taking antiplatelet and anticoagulant drugs. To treat these patients ethically, we need to have an idea on the most commonly used anticoagulants, their mechanism of action, their dose, and when to alter, stop, or get a physician consent regarding the usage of anticoagulant or the blood thinning drugs. Being dental surgeons, as I've told you, we come across bleeding every single day of our life. And this bleeding is stopped by the initial word that we have used. The bleeding is stopped by something called as hemostasis, the process of hemostasis. Hemostasis literally begins with the platelet plug formation and later carried on by the coagulation cascade, which has got the intrinsic and the extrinsic pathway mechanisms. So now we shall have an overview on the how platelet plug is formed and what is the action of some of the most commonly used antiplatelet agents. And if you consider this to be a blood vessel, this is a blood vessel. And as you all know, our blood vessel is made of endothelial cells. During an injury, this blood vessel is injured. During an injury, what happens is there is an exposure of collagen, which is an inevitable protein that makes the integrity of the cell, the wall of blood vessels. This exposed collagen has got the capability of attracting platelets to the region. While the platelets come and adhere to the collagen, they get activated and they produce some kind of chemicals, predominantly thromboxane A2 and adenosine diphosphate. These chemicals have got the property to attract more platelets to the area of injury. So when these chemicals are produced by the platelets, these chemicals in turn makes more platelets to adhere at the area of injury. Following this, there is deposition of fibrin bands, RBCs. Again, there shall be the deposition of platelets at the area of injury. And again, there shall be the deposition of a fibrin band. As a result, you get something called as a clot. Clot is good because it prevents bleeding. It is otherwise called as a platelet plug. Now, coming to the action of one of the most commonly used antiplatelet drug, aspirin, which is commercially available in various names. We'll come about it later. Coming to aspirin, as the name suggests, aspirin is an irreversible COX-1 inhibitor. That is, our body is made of cells. We do have cell membranes, no cell wall. So our body is made of phospholipid cell wall, a cell membrane. And during injury, this phospholipid is converted by phospholipase A2 enzyme into arachidonic acid. This, with the help of the COX enzyme or the cyclooxygenase enzyme, gets converted to thromboxane A2 and prostaglandins. Of this, thromboxane A2 is helpful for platelet adhesion and aggregation, as we have discussed earlier. And as the name suggests, aspirin is a COX-1 inhibitor. So aspirin, for a patient taking aspirin, aspirin inhibits the activity of COX-1 enzyme. As a result, thromboxane A2 is not produced. If thromboxane A2 is not produced, there shall not be any production of the platelet plug by platelet adherence or adhesion. So that is the mechanism of action of aspirin. Now we have newer novel antiplatelet drugs like clopidogrel, prasugrel, ticlopidine, and ticagrelor. So we have the two grels, that is the clopidogrel and the prasugrel. Then we have the ticlopidine and ticagrelor. They are just ACP receptor antagonists. As I've told you, ADP, that is adenosine diphosphate, is required for the adhesion of platelets to the area of injury. And clopidogrel, prasugrel, ticlopidine, and ticagrelor are ADP receptor antagonists. So they will inhibit ADP from adhering to the receptor site. As a result, what happens is there will not be any platelet adhesion or attraction to the area of injury. That is how the antiplatelet drugs, clopidogrel, and the rest works. We also have a very important antiplatelet drug that is very commonly used in hospitals. That is eptifibatide. Eptifibatide is a glycoprotein receptor antagonist. It being a glycoprotein receptor antagonist, it will not allow glycoprotein to adhere to the receptor sites. Glycoprotein also helps in the platelet aggregation and the adhesion phase. So when it cannot adhere to the receptors, its activity will not take place. And as a result, antiplatelet activity prevails. That is the mechanism of action of eptifibatide, that is otherwise called as intergelin. And now we have discussed on the platelet plug formation and most commonly used antiplatelet drugs, including aspirin and clopidogrel. Now we shall go into the coagulation cascade, which is the next process that helps in the clotting mechanism. And here, before that, I will just enumerate what are the antiplatelet agents. all of them has been told. We have aspirin. It is called as Kersia, aspect, ecospirin, the most commonly used name. Also ecospirin gold, when aspirin comes as a combination drug along with statins. This is a dual drug where aspirin comes into contact, aspirin and clopidogrel are in combination with statins. And the other names, clopidogrel, Plavix, very commonly used, very commonly seen, prasugrel, FVN, and ticagrelor. And integrilin, as I've told you, eptifibatide. And at this slide, you have to keep at the back of your mind that antiplatelet activity cannot be monitored by any of our lab parameters. We can have a gross idea about the platelet activity by the bleeding time or the clotting time, but the actual activity of these antiplatelet drugs on blood cannot be monitored by any of our lab parameters. Now coming to the coagulation cascade. Coagulation cascade, we have coagulation cascade has the extrinsic as well as the intrinsic pathway. Intrinsic pathway is otherwise called as the amplification pathway because it only amplifies the clotting process. It will never start up a clotting process. So intrinsic pathway is otherwise called as amplification or contact pathway. This is because blood, when it comes into contact with external surface, like that of a negatively charged test tube in a laboratory, it clots. So intrinsic mechanism is the mechanism by which blood clots in a laboratory test tube. And intrinsic mechanism, I have to tell you that activated forms of all clotting factors are represented by small letter A. So there is a formation of factor 12A from factor 12. This is being converted to 11A, 11A to 9A, and 9A to 10A. This 10A converts prothrombin to thrombin, which is essential for the conversion of fibrinogen to fibrin clots, which is rather unstable, later being stabilized by the fibrin stabilizing factor, which is factor 13. And we also have an extrinsic pathway. This is an initiation pathway. It takes place during the beginning of an injury. So this is also called as initiation pathway because it kicks up at the same time when the injury has occurred. And in the extrinsic pathway, tissue factor is produced, which is the factor 3, that converts factor 7 to 7A. This tissue factor along with factor 7A causes the conversion of factor 10 to 10A. So this is the common pathway here. That is, extrinsic and intrinsic pathway meet at the junction of conversion of factor 10 to 10A. So this is the common pathway. And one of the most commonly used anticoagulant is heparin and the low molecular weight heparin. They are short-acting anticoagulants as well as rapid-acting anticoagulants. In our body, endogenously, a substance called as antithrombin 3 is present. Heparin and low molecular weight heparin taken by patients for prophylactic or therapeutic use is a antithrombin 3 activator. And as the name suggests, when antithrombin 3 is activated, it is anti to thrombin. So it will inhibit the production of thrombin, that is 2A, as well as factors 9A and 10A. If factors 2A, 9A, and 10A are not produced, the coagulation cascade will not be complete and there shall not be any clot formation. And this is the mechanism of action of the anticoagulant heparin and the low molecular weight heparin. They are shear antithrombin 3 inhibitors, activators, and hence they inhibit the production of factor 2A, 9A, and 10A. And there are no novel anticoagulants, literally dabigatran, which is a direct acting oral coagulant. And this dabigatran is a thrombin inhibitor. And the sebans, you will come across daily in your prescriptions during your dental practice. The sebans, we have got apixaban, edoxaban, and the rivaroxaban. How does the sebans work? They are factor 10A inhibitors. So while taking the dabigatrans or the sebans, they inhibit the production, the formation of thrombin or the factor 10A. As a result, the coagulation cascade will not be complete. That is the mechanism of action of this direct acting anticoagulants, and the anticoagulant activity prevails. So we have discussed on some anticoagulants here. And just because we have discussed on the anticoagulants, we will have a say on the most commonly used fibrinolytics and antifibrinolytic agents here. What are fibrinolytic agents? Fibrinolytic agents, as in case of a thrombotic stroke, patient is taken to a tertiary care hospital within 3 hours, and they have a set protocol, and we always say the patient has been given some kind of a thrombolytic agent or fibrinolytic agent. They are nothing but tissue plasminogen activators. Thrombinolytics or tissue plasminogen activators are streptokinase and urokinase. Now, coming to the common pathway, in our body we have something called as plasminogen. When it is converted to plasmin, it can cause the degradation of the formed fibrin clots. Tissue plasminogen activators, what they do is they activate the plasminogen to produce plasmin, which in turn degrades fibrin. There is disruption of fibrin. That is what you call the thrombolytic or the fibrinolytic activity of the tissue plasminogen activators, streptokinase and the urokinase. And coming to the, just because I've told on the about the fibrinolytics, I would just have a say on the most commonly used antifibrinolytic drug in our dental practice to stop bleeding. That is nothing but tranexamic acid. I've told you, thrombolytics are tissue plasminogen activators, while the tranexamic acid is a plasminogen inhibitor. It will inhibit the activity of plasminogen. So plasmin will not be produced. If plasmin is not produced, degradation of fibrin or the destruction of fibrin clots will not take place, and the clot will be in position, and there shall be stoppage of bleeding. And last but not the least, we have talked on everything, but we haven't discussed on one of the most commonly used anticoagulant, warfarin. This is warfarin. In our body, we have certain weird acids, like the glutamic acid. When that combines with the oxygen and carbon dioxide within our body, they form something called as gamma carboxyglutamic acid. This gamma carboxyglutamic acid is helpful in the production of clotting factors 2, 7, 9, and 10. For this conversion of glutamic acid to gamma carboxyglutamic acid, we need something called as reduced vitamin K. And we all know reduced vitamin K is produced from the vitamin K cycle, where vitamin K is converted to oxidized and reduced vitamin K with the help of the enzyme vitamin K reductase. Warfarin, the most commonly used anticoagulant drug, is a vitamin K reductase inhibitor. So it inhibits the activity of vitamin K reductase. So vitamin K will not be converted to reduced vitamin K. Hence, glutamic acid cannot produce these clotting factors, and as a result, the anticoagulant activity proceeds and no clotting or coagulation occurs when patient is taking warfarin for some prophylactic or therapeutic use. And just to enumerate on the anticoagulants, we have told heparin and low molecular weight heparin. These are short-acting, also rapid-acting anticoagulants. We have argatroban, and we have the coumarins. That is, coumarin derivatives include warfarin, SNO-coumarol, and bis-hydroxycumarol. Then we have something called as dabigatran. Dabigatran is, as we have discussed, is a thrombin inhibitor. Then we have the sabans, including rivaroxaban, edoxaban, and the apixaban. And these are the in vitro agents. Just for the sake of completion, I have added this. We can leave that aside. Now, when shall we stop on the warfarin? When shall we stop warfarin or oral anticoagulants based on the INR value before an oral surgical procedure? That is, INR value is international normalized ratio. That is, prothrombin time of the patient divided by the prothrombin time, which is normal. Prothrombin time is nothing but the clotting time of blood expressed in seconds based on the extrinsic pathway of coagulation. We talked about the intrinsic and extrinsic pathway. So it is based on the extrinsic pathway of coagulation, and its normal value is said to be 12 to 40 seconds. For a patient taking anticoagulant, we know the clotting time is prolonged. Say that to be 60 seconds. So prothrombin time of the patient divided by 12, which is the normal value, the INR value comes to 5. If the INR value is between 2 to 3 for a patient taking anticoagulant, or at the maximum of 3.5 or 4, in such patients, we can do mild to moderate dental procedures without the stoppage of warfarin. But if the INR value is above 4, and the patient has to be conducted for a surgery which will have severe bleeding, and it is an invasive procedure, and patient has got some comorbidities like some liver disease, bleeding disorders, or chronic alcoholism or something. In such patients, we cannot operate on the patient. We would refer the patient for a physician consent. So this is the normal value of INR value for a patient taking anticoagulant. This is for a normal patient without anticoagulant. And in such patients, when the INR value is above 4, we will ask for a physician consent. But the physician wouldn't stop on warfarin for a reason. It may aggravate the disease condition if they stop on the anticoagulant drug. Warfarin being a long-acting anticoagulant with a half-life of around 72 hours. Before surgery, before 5 days prior to surgery, warfarin is stopped by the physician, and he will start on heparin, which is a rapid short-acting anticoagulant, up till the day of surgery, and would stop heparin 6 to 12 hours prior to the surgery based on its dose and the therapeutic value. Post-operatively, measuring, if monitoring the bleeding, if there is no severe bleeding, the doctors shall restart on heparin along with warfarin. This is continued until the amount of warfarin in blood for the patient taking anticoagulant is normalized based on the INR value. That is, it is literally a bridge, starting with warfarin. Because it is a long-acting drug, it is stopped before surgery. Then comes heparin. You restart on warfarin. And post-operatively, you restart on heparin and warfarin together until and unless the activity of warfarin is normalized in blood. And just because we have talked on warfarin and heparin, we need to know on some of the antidotes. For a patient who has undergone an emergency surgery and he is taking heavy doses of warfarin, or a patient has a chronic liver disease, or a patient taking severe quantity of anticoagulant, has got a trauma and is bleeding profusely, or we take a patient accidentally for a dental procedure and there is severe bleeding from the patient. We did not know the history of the warf being taken by the patient. In such cases, we can use vitamin K injections. Vitamin K injections can be used. Even in your dental office, you can use. That's not an issue. Vitamin K injection can be given 10 milligram subcutaneously once daily for 3 days till the bleeding is controlled. As I've told you, vitamin K is required for the production of 2, 7, 9, 10 factors of clotting. So it helps in the coagulability of blood. Protamine sulfate is the antidote for heparin. It is mostly used in cardiac surgeries. And we have discussed on the prothrombin time. Prothrombin time is nothing. When we talked about INR value, we discussed on prothrombin time. Prothrombin time is nothing but the clotting time of blood that is expressed in seconds based on the extrinsic pathway of coagulation. Because it adds the extrinsic pathway, we have the factors 3, 7, 10, 5, and 2. And the normal value, as I've told earlier, is 12 to 14 seconds. For a patient taking anticoagulants, it will be more. And we also have something called as partial thromboplastin time. It is nothing but the time of coagulation, time taken by blood to clot, based on the extrinsic mechanism, based on the intrinsic limb of coagulation pathway. And it holds the factors 12, 11, 9, 8, 10, 5, and 2. Just because it holds the factors 11, 9, and 8, it is held as a measure. If a hemophilic patient comes to our clinic, we need to know the clotting time of such a patient. We should have a check on the partial thromboplastin time, not on the prothrombin time. Prothrombin time is based on the extrinsic pathway. So by the prothrombin time, we will not get the clotting time in patients with the hemophilia. Activated partial thromboplastin time is nothing but an activator is added during the lab procedure, and the clotting time range has come down. That is, it has come down to 30 to 40 seconds. That is what you call the activated partial thromboplastin time. And now coming to the bleeding disorders, we have told about the hemophilics, and so just to have an overview, we may come across patients with hemophilia in our clinics. Hemophilia A is due to the deficiency of clotting factor 8, B is due to the deficiency of clotting factor 9, and C is due to the deficiency of clotting factor 11. And we have something called as the von Willebrand disease, which is caused by the deficiency of von Willebrand factor, which is nothing but the carrier protein for clotting factor 8. And such patients, we have certain blood substitutes that can be given in terms of bleeding or bleeding injuries or diseases. Coming to whole blood can be given to patient who has got severe bleeding or hypovolemia. And whole blood contains almost all factors of coagulation. And then we have platelet. Platelet is given to conditions like thrombocytopenic purpura, in which the level of platelets have come down and we have to add platelets. And there is fresh frozen plasma, which contains predominantly factors 9, 1, and 8. So in hemophilia patients who are bleeding severely, we can substitute with the factor 8, 9, or 1. We also have cryoprecipitate, which has got von Willebrand factor, factor 13, factor 1, and factor 8. This can be given for hemophilia and the von Willebrand disease, and for stabilizing the clot as well as to stop bleeding. This is cryoprecipitate. And there is a newer advent called as the Thrombolastography machine. If a patient has got severe bleeding or a bleeding condition, the whole blood of the patient is being fed to a something called as a Thrombolastography machine that assess the quality of platelets and the clotting factors, and with the help of certain graphs, it would suggest what is the kind of substitute we need to give to the patient, including the clotting factors or the platelets or the plasma, or it is very specific machine that can be used in tertiary care centers. Now, coming to the hemostatic agents. Hemostatic agents can be mechanical, thermal, or chemical. Coming to the mechanical methods, we take a tooth out from a patient. There is bleeding. We tell the patient to hold clench cotton to the area for some 5 to 7 minutes. This is to stop bleeding, because bleeding time is some 2 to 7 minutes, and this is to stop bleeding. Followed by, there is a period called as clot formation period that takes some 8 to 13 minutes. But we tell the patient to hold the cotton for 1 to 2 hours. This is literally done so that we do not disturb the clot, obviously. And also for a reason, during this period, the clot loses much of its water. It organizes, strengthens, and it becomes more stabilized. That is why we tell the patient to hold the cotton for some 1 to 2 hours extra. That is taking into account the clot retraction time or clot retraction period. We have hemostat. That is seldom used in dental procedures, but if we are doing some maxillofacial procedure and there is an open vessel while during a maxillofacial surgical procedure, and we have a vessel that is open and is bleeding profusely, we would hold it with the help of a hemostat, then cauterize the vessel with the help of a monopolar cautery, or some kind of a ligature wire or a suture material. Suture, it is the most commonly used hemostatic agent. And it is just used for the approximation of tissues, not to tie the tissues together. It is just for the approximation of tissues. Then we have something called as ligation. Again, in major surgeries, when we have an open vessel that is bleeding during a surgery, we use suture threads or ligation wires to ligate the area. You hold it with the hemostat, then tie it by ligation. Might be with the surgeon's knot or a modified surgeon's knot. And we have something called as surgical staples. Surgical staples are much easier when to use when compared to the suturing technique. Then we have cyanoacrylate blues. Cyanoacrylate blues, by polymerization, they would help in the approximation of wounded tissues together. And we also have the cyanoacrylate steri strips or bandages. This is again used for the approximation of the lacerated tissues together so that we can achieve hemostasis. Then surgical clips, again, we go into maxillofacial surgery or open surgical procedures where we have a bleeder from a vessel and you clamp it or rather clip it with the help of surgical clips, with the help of an instrument. Now coming to thermal methods of achieving hemostasis. First is electrocautery. This is a electrocautery that we use in our theater there, and this is a portable electrocautery. This can be easily taken by surgeons who have clinical practice, because if you keep that at the back of your car, that can be regarded as a very good method to achieve hemostasis. You will be so very confident when you have a portable cautery in your vehicle while you travel and practice. Here, heat causes coagulation of blood. Heat is produced and this causes coagulation of blood. This is monopolar cautery, this is bipolar, and Valley Lab is the company. And this is a bipolar cautery. Now we have something called as cryo surgery. Here also, hemostasis is achieved by high freezing temperature that range from -120 to -180 degrees Celsius. It causes cryonecrosis with the help of certain gases like nitrogen and argon. So here cryonecrosis takes place. Surgical ice packs. We tell the patient, after taking a tooth out, we tell the patient to eat ice cream or keep ice while after going home. This is done to minimize the inflammation in the area as well as to get vasoconstriction and stoppage of bleeding. Argon beam coagulator, again the lysing agent being argon, and this is used to coagulate the bleeding vessels. Laser, light amplification by stimulated emission of radiation. We have the CO2 lasers and the erbium lasers. It can be used with confidence in patients who are taking anticoagulant drugs for minor surgical procedures. And the lasers, they work on the principle of heat. At a very low temperature, they give hypothermia, while at a temperature up to some 50 to 70 degrees Celsius, they cause coagulation. Above that, they would help in the cutting of tissues, and at higher temperatures up to some 100 or above, it causes charring of tissues. Now coming to hot ball varnishers, it is no problem that you use a ball varnisher as a thermal method of to achieve hemostasis if you find a small bleeder during your practice in dental clinic. But the ball varnisher need to be sterilized, and it shall be solely used. It shall be only used for this purpose, and it should be autoclaved. And coming the last kind of chemical methods. Here we have got something called as astringents. Astringents causes constriction of blood vessels, Ferric sulfate solution is an example. It is otherwise called as the Monsell solution. This solution can cause vasoconstriction and hence prevent bleeding and achieve hemostasis. Tannic acid is present in tea bags or green tea, tea leaves. Tannic acid is a coagulable agent. Then we have bone wax. It is an irresorbable material. It can be used to seal a bone surface that is bleeding. It can be used as a mechanical barrier or a tamponade. But keep this at the back of your mind. Bone wax is irresorbable. So if you use that in your daily practice and you take an impacted tooth out and keep it there, it shall be there. It will not resorb out. And we have thrombin, Recothromb by Pfizer. You know the property of thrombin. I have told in the coagulation cascade. Thrombin converts fibrinogen to stable fibrin clots. This is made use of while using thrombin as a hemostatic agent. That is, it is used with the help of a gauze or a pack. Thrombin can convert fibrinogen to fibrin and form a stable clot in the area and hence stop bleeding. Then we have got gel forms. Gel forms is made from gelatin. It can absorb around 45 times of its weight. It can absorb the oozing blood or the fluid. It increases in size, exerts pressure, and acts as a scaffold for fibrin network. Gel form. Then we have Oxycel. Oxycel is nothing but it is oxidized cellulose. Again, this can be kept on a bleeding wound. Cellulose is nothing but a foreign body. And I have discussed in the intrinsic pathway that when it comes into contact with the external surface, here the cellulose, it kickstarts or activates the intrinsic pathway, and as a result, blood clotting takes place. This is the action of cellulose. It is based on the contact pathway. We also have Surgicel. It is a resorbable suture material. It is also cellulose. So the intrinsic coagulation cascade gets activated when blood comes into contact with the external surface and clotting takes place. So Surgicel is also a hemostatic agent. Then we have Fibrin Glue. Fibrin Glue is nothing but thrombin that again converts fibrinogen to fibrin. That can be used to prevent bleeding or for hemostasis during surgical procedures. Botrophase, it is derived from snake venom. It is a hemocoagulase enzyme. It clots or it causes coagulation of blood, and blood doesn't bleed. It is very commonly used in our department. And then we have Anticollagen. Anticollagen is it's a brand name. From here you have to take collagen. As I've told earlier, collagen has got the peculiar, collagen is a protein. It is exposed during injury. And collagen has got the capability of attracting or entrapping platelets at the site of injury. So anticollagen, we add packed collagen to the site of injury so that hemostasis is speeded up. Then we have avitin. Again, avitin is nothing but collagen. Collagen causes the entrapment of platelets as well as it attracts more platelets to the area of injury. So that is made use of while we use avitin to stop bleeding in injured sockets. And would a surgeon use 1:1000 solution of adrenaline topically? My answer is a big no. Just because 1:1000 solution of adrenaline can cause severe tachycardia, some cardiac arrhythmias, and even at a later stage can go in for something called as a cardiac arrest, because we are practicing in a very, very limited condition in our dental clinics. 1:1000 solution of adrenaline is never advised. If you want, you can you can use the 1:2 lakh or the 1:80,000 adrenaline that is mixed with our local anesthetic solution, and that can be used as a local hemostatic measure, never a 1:1000 solution of adrenaline. There are reported cases when I talked with the anesthetist in our hospital. He was telling the same. Even 1:10,000 for a ophthalmic condition has caused severe arrhythmias and cardiac related problems to the patient. So it is seldom used now, especially topically. And to end with, we have something called as tranexamic acid. Tranexamic, it is found as hexacyl. Tranex is available as tablets, capsules, and ampules. As we have discussed earlier, it is a plasminogen inhibitor, so it inhibits plasminogen so that plasmin doesn't get produced. As a result, fibrin clots will not be disrupted. Tranexamic acid is given as 500 mg or 500 mg. It is got as 500 mg tablets or capsules. Also 650 mg is available. This is a 500 mg ampule. We would be giving, for severe bleeding cases, we would be giving 1000 milligram literally thrice daily. And we have the ampule, which is 500 mg, but we would inject only 50 milligram per minute. It's an anti-fibrinolytic agent, tranexamic acid. It is invented way back in 1956. It is a surgeon's friend. We have used any number of times, and it has helped. And to conclude, every body is a book of blood. Wherever we are opened, we are read. And I would like to, I've just finished on my topic, and I would like to thank Shyam Sundar sir, the president of SmartCiy branch Kochi, along with Sunil Alexander sir, who is the secretary, Dr. Deepak Thomas, the chairman CDE, SmartCiy branch Kochi, and all the delegates, including teachers, students, and all other doctors who have given their valuable time. I also like to thank the principal sponsors, Janomed, MedPiper, and the people who have helped, like Snigdha and Soumya. And to remember, doctors are students in every day of their lives. The day when they stop learning, they tend to be no more doctors, or they are no longer considered as doctors if you do not study and update. Thank you. Thank you so much for your patient listening. It's a good crowd. Thank you.
Thank you very much, Doctor. It was a very wonderful presentation. Shyam Sundar.
Yeah, Shihad, it was a wonderful presentation. I think we have some questions from the audience, if we can go through that, and a couple of questions if we can answer, that will do a word of good.
Activated partial thromboplastin time and partial thromboplastin time, they are both the same. But in the laboratory conditions, they add some kind of an activator so that the clotting range will come down. That is it. Both are literally the same. Till what dosage of aspirin intake patient we should stop the drug or get consent from physician, or should we stop aspirin in all cases? In my practice, for 75 mg or 150 mg, there is, as I've told earlier, we do not have any specific lab parameters for the stoppage of the drug aspirin. So if we need a bloodless field while doing a procedure, and if the aspirin dose is some 150 or 300 mg, you should take a physician consent if you are stopping on the drug, because that may aggravate the patient disease condition, and go forward. And if you have the yeah sir, if you can add.
The current guidelines doesn't ask us to stop aspirin. If it's just aspirin, the current guidelines, we don't need to stop. That should be the thing. Even if it is 75 or 150, it's fine. But if it's a combination drug, like you have both aspirin and clopidogrel, still you can do it, but with caution. Probably you can expect some bleeding, but still you can do it. But we have been following this old protocol from long time.
Yeah, exactly.
So we are sticking to the old concept of, but nothing wrong in asking a physician consent, because that will always keep your practice safe.
Yeah. And which cautery is recommended for clinicians? We may get a portable cautery at the price of some 12 to 15,000 rupees. It will have a earthing end as well, and that can be safely taken. Sir, anything to add, sir? Sham sir, on
this office cautery which we buy, you should have at least 2 to 3 tips, different tips. Like what the cautery we use in theater, similar one, we'll have a pencil sort of thing, like a Colorado tip. Then we'll have a ball varnish sort of tip is there,
Yeah, sir.
2 different types. So depending on the area which we want to cauterize, this can be used, especially for socket bleeding. This round type of tip, the ball varnish sort of, the tip is very, very much useful than the pencil like one. So if you buy an office cautery, at least 2 to 3 different tips we should be having. So that is the thing, Brand, I'm not very sure about, the office cauteries.
Yeah,
but there are a lot of
n number of brands are available, sir. Some 12,000 to 18,000, you could get the best, I reckon. And sir, while keeping the gauze for 1 to 2 hours, on the fibers of the gauze get entangled with the clot.
That is a tricky question,
Yeah,
I'm not very sure about how it is, but we don't instruct usually for 1 to 2 hours, but certain patients are like really worried about the bleeding. So in such patients, to calm them down, we might ask them to keep for half an hour to 1 hour. But I don't really think it will disturb. If you remove after 1 hour, nothing is going to happen. This is what I think. I'm not sure about it.
Yeah, sir. That's about the question, sir.
So that's those are the questions, right?
Yeah, sir. 4 questions. Yeah.
Okay, so I think you have covered almost the entire spectrum of hemostasis, the mechanisms, the drugs what we use, and probably maybe you can add on some scenarios where a real scenario where a patient is having multiple medical complications, like a patient on warfarin for different reasons. Sometimes it will be a neurological reason, sometimes it will be for a cardiology reason. Some people on post valve replacement. So these are the different scenarios. So
post valve.
Post valve replacement. So whenever I've discussed this with my cardiologists or physicians, so their approach to these different conditions are in different ways. So 2 weeks back, there was a patient who was on warfarin, but not on for valvular disorder. My cardiologist advised just to take the INR, and he in fact asked me to do the extraction. So I was very much surprised, but I don't know exactly why he said that. Maybe the warf, even after having warf, the INR was around 1.5. He asked me not to stop it, and he asked me to do the extraction. So I don't know the exact reason behind it. So there are the different scenarios, the physicians or the cardiologist give their opinion in different ways. So I think I'm not the right person to shed light on it. Probably, I think we should inquire more to a cardiologist or somebody.
Yes. Thank you, sir.
Thank you, Shihad. Very good presentation.
Thank you.
Shall we conclude, Shyam sir, Sunil sir?
Please, please go ahead. Please go ahead.
So on behalf of Idea Smart City, I would like to thank our speaker, my dear friend Shihad Salim. It was an excellent session, and in fact, Smart City branch members will be very happy today because we have set a new record today. Almost 325 candidates have attended the program, and nearly 400 registrations were there. I have to check into that, but definitely 325 candidates have attended the program. That's a new record for a branch which has been started 2 years back, and we are very glad about that. And we also would like to thank the delegates who have registered from all over India. We have got many registrations from Mumbai, Gujarat, etc. And in fact, few of our friends, our juniors, have also attended the talk from US also. That's a very glad thing about that. And the other thing is that we would like to tell thanks to our dear teachers. The teachers, in fact, Shyam sir is the president of Idea Smart City, and Jos Paul sir has also attended the talk, and other senior faculties and teachers who have attended the talk. We are thanking them for making this a great success. And we also thank the MedPiper technology for supporting us. And last but not the least, I would like to tell one more thing. In the Chingam Onnana, നമ്മൾ ഓണത്തിന്റെ ഒരു സീസണിലേക്ക് കടക്കുകയാണ്. അപ്പോൾ സ്മാർട്ട് സിറ്റിയുടെ ഓൺ ബിഹാഫ് ഓഫ് ഐഡിയ സ്മാർട്ട് സിറ്റി എല്ലാവർക്കും ഹൃദയം നിറഞ്ഞ ഓണാശംസകൾ.